Yes, sir.
All right. So just 30 minutes. We'll finish. Kind of special situation when the resistance sets in. So definitely most of the medicines that are used in the management of the resistant types, we are not familiar. Of them are not common medicines. And therefore, I would advise that we shouldn't as worry so much if the regimens become cumbersome and we seem not to understand. But at least note this important slide, at least the next two slides that you are going to look at. Just note them. The combinations into memory. No, it's not even sensible to do that. But note that when it comes to the multi-drug, are normally combined for the management. At times, the condition may even be resistant to normal fluoroquinolones. And then the two drugs that are the backbone of the medicine, as in the management, isoniazid. That these drugs are used when it comes to the management of the resistant types of TB. In general, when it comes to the long regimen that we have for the multi-drug resistant TBs, these drugs called second-line agents, the ones that we use for the management of the susceptible ones are termed first-line agents. So rifampicin, isoniazid, ethambutol, parazinamide, these are first-line agents. And when resistant gets in, then second-line agents will be used. These agents are also grouped into three main groups. That is Group A, Group B, and Group C. For the long regimen, it is advised that you include all the three drugs classified under Group A. So fluoroquinolone, either levofloxacin or moxi, bedaquiline, and linezolid. You may have to include all. Then for the Group B class, you add one, at least one to it. Depending on the extent of susceptibility or resistance, you may have to add both. So that one contains clofazimine, that is also active against Mycobacterium leprae, the one that causes leprosy. Then cycloserine or terizodone. Then you may add one of the Group C agents, including ethambutol and the rest. As I said, do not chew this or commit them into memory, because this becomes more like a specialist case where the infectious team will have to imagine this combination. There is no way you can commit this combination into memory or this regimen into memory. But note that when it comes to the multi-drug resistant TB, we can have the standard, which is also known as the long regimen, or you can have the short regimen. For the long regimen, it can take a duration of between 20 to 24 months to manage multi-drug resistant TB. You are going by the standard regimen, then it can take that long. And of course, the drugs that are combined are mostly those referred to as second-line agents. So you can see the injectables, the TB injectable medicines. You can see either kanamycin or capromycin. You can see levofloxacin, butanamide, cycloserine. Do not commit this into memory. Then the so-called shorter regimen for the multi-drug resistant TB, of course, will take a lesser duration of therapy, 9 to 12 months as compared to 20 to 24 months. Of course, once you are shortening the duration, then it means the doses and even the number of drugs in the shorter regimen will be higher as compared to the longer regimen. Do not commit this into memory, but at least note that there is a standard regimen, also known as the longer regimen, that may take 20 to 24 months. The shorter regimen for multi-drug resistant TB takes 9 to 12 months. This possibly for MCQ purposes. I'm not sure anybody will set a question for you and ask you to treat multi-drug resistant TB, but you just need to know. You just need to know. So it's the same thing that has been explained in this slide. It's the same thing. When you want to consider specific resistance, especially whether there is resistance to the fluoroquinolone or not, then we have this regimen. And depending on the patient's age and the susceptibility pattern with reference to quinolones, then those who are above or equal to 6 years, the duration may take 9 to 11 months, and those 14 years and above, 6 to 9 months. That goes with quinolone resistance. So just note this at your own free time. You go through the drugs. Familiarize yourself with the drugs and note specifically the durations. Once you know at least about the durations, it should be enough. But the whole combination, at times combining 8 drugs, 10 drugs, you can't simply commit this into memory. It's not even advisable to do that. But note this. If somebody comes with an extensive TB disease or a severe form of extrapulmonary TB, then of course, this will be treated according to susceptibility pattern. Then the team will have to analyze. It should be an individualized treatment. You are not going by the normal guidelines that say that if it is this, do this. For extensive extrapulmonary TB or extensive pulmonary TB infections, you are going by individualized therapy. You test the person for sensitivity so that will guide your selection of medicines. So these are all same. When it comes to pediatric management, the most important thing is that previously there used to be regimen that contain relatively lower strengths or lower doses. And now, to prevent treatment failure and development of resistant strains, the doses have been upgraded. So for example, you can see the combination tablet that contains rifampicin, isoniazid, and ethambutol and parazinamide. The doses were 60 milligram, 30, and then 150 respectively. So for rifampicin, isoniazid, parazinamide, previously, this was the doses or the strength, 60, 30, 150. But now it has been increased to 75 milligram rifampicin, 50 milligram isoniazid, and parazinamide, maintaining the old 150. And therefore, according to the child's weight, that goes with the number of tablets that they can take. So the only difference is the increase in strength of especially rifampicin and isoniazid. These are the backbone when it comes to TB management. To improve efficacy and to avoid development of resistant strains. Now, the strength and for that matter, the doses of especially rifampicin, isoniazid have been increased. Therefore, this is no more used. The lower regimens are no more used. And now this is the current recommendations for PDs. Monitoring is key. Not only in this field. Yeah, hello?
So please, could you explain the slide with the extra pulmonary TB, how to manage that?
No, they are saying that when somebody comes, and even if it is pulmonary TB, but you are having the resistant type that is extensive, or somebody comes with severe form of extra pulmonary TB, that one is not about going strictly by guidelines. If it is fluoroquinolone resistant, then use this combination. If it is this, go by 3 months. If it is this, go by 6 months. You have to do individualization with sensitivity testing. So that one, yes, guidelines are there, but look at the patient. Test the patient for sensitivities. All the drugs that you can combine, including first line, second lines, which one are so sensitive? Which one can still cure? Because you are having an extensive form of TB that is multi-drug resistant or even rifampicin resistant. And therefore, you need to select only drugs that can kill it. You can't just go for the guidelines. Meanwhile, the drugs in there, the one that you are picking, there is resistance against them. So test. And then you know the susceptibility pattern. Then you make your combination therapy. Same goes with when there is extra pulmonary TB and it is severe. You have to do individualization of therapy. What is this? Based on the person, based on the severity, test for sensitivity, do your selections. The duration of therapy may not even go with the normal recommendations of 24 months, 20 months. You individualize the therapy. That is all that they are saying. Are you okay? And of course, this is for infectious team. It's not just any GP who is going to do it. But because of the nature of these forms, severe extrapulmonary, multi-drug resistant one, that susceptibility pattern among the recommended medicines, first line, second line, to know which ones to select. When it comes to duration of therapy, it depends on the case that you are handling. When are you going to have no more of the TB on sputum? When are you going to have better results per X-ray? That is how you should manage it because of the severity of this form. Are you okay?
Thank you, sir.
All right. So now it is very important that you monitor individuals with TB infections. For success to occur, monitoring is very important. You monitor always for efficacy and toxicity in all situations. With TB, we do both clinical monitoring and laboratory monitoring. In situations where laboratory monitoring is not applicable, then you may have to go with clinical monitoring. But how do we go about it? Of course, in children, it even becomes more serious because they may not even understand the whole regimen. Why are they taking medicines for that long? 6 months, 8 months. And for that matter, in children and adolescents, they need close monitoring. And of course, a very deep counseling to motivate them so that they do proper adherence. Chemotherapy is all about you are not lucky, resistant traits will be developed. So when it comes to children, it is very, very important. So let's look at some of the monitoring strategies when it comes to clinical. We have to check for symptoms, resolution, and weight gain. Of course, this means that we are winning because one of the key goals of therapy is to what? Clear the signs and symptoms. And of course, in TB, weight loss is there. So if it reverses and we get weight gain, then it means that we are enjoying efficacy.
Okay, I said I'm going to school in August. All my things, I don't know if I'm speaking. Where's all of them again?
Hello. Ask Captain, can you mute the person? All right. And for that matter, per every visit, you therefore need to weigh the patient and then you confirm whether we are having any gains. Improvement in weight means there is what? Improved efficacy. It is also key if you have treatment monitors or supporters. This is just like when you are managing HIV and you have these mentors or monitors. It has been found that when individuals are able to disclose and accept these supporters or mentors, it's able to improve the efficacy. Pharmacovigilance is key because look at these number of drugs that you are going to combine. Some of them are very potent medicines that may cause severe adverse drug reactions or adverse drug events. And therefore, as part of the monitoring, we have to take note of possible adverse drug reactions. Ones that are not even expected, ones that are not even part of the drug profile could happen possibly because of the potency of the drugs and the multiple combinations that we do. Of course, once there are issues, very dangerous issues like hepatotoxicity and any other organ abnormalities, it's important to halt the management, review, and possibly come back again. When it comes to adolescents and children in particular, if through pharmacovigilance, any of these are suspected or identified straight away, if it's not in the hands of the specialist, then it should be referred to the specialist. Lab monitoring. All the labs that are used in the detection of the conditions may be included in the monitoring. Example, chest X-ray, sputum analysis. As for GeneXpert, it may be reserved for only diagnosis. But apart from the clinical monitoring parameters that are recommended for labs may include sputum. Once you go for sputum analysis and you don't find any, you don't isolate the TB again, then it means that you've cured the condition. If chest X-rays are back to normal, you don't have any of the characteristics typical of TB infections, then it means that it is going well. As I said, for younger individuals in particular, if maybe for one or two reasons you cannot have access to labs, then it is okay. Obviously, it's not even only young children or pedics. The moment you don't have access to laboratory monitoring, then your only option will be clinical monitoring like weight gain and reversal of signs and symptoms. Again, adherence is the key. Adherence is the key. And therefore, if adherence is not on point, treatment will fail. And therefore, family members, supporters are all supposed to be engaged so that they help. Discrimination do not have any place when it comes to TB management. Same goes with HIV. If you discriminate against morally, you depress the patient and it brings a whole lot of social issues. So you need to embrace them, fine. As long as they are on medicines, it is expected that at least within the first 2 months for drug susceptible TB, the load will be suppressed and possible infections will not be there. And therefore, we are not supposed to do discriminations and suppress them morally. Yes, so all these labs are supposed to be done. Now, when it comes to TB, we did this in HIV. Once the person is diagnosed with HIV, nowadays, the guidelines is that we should do TB preventive therapy for the person, especially when the immunity is low in the initial stages. But before you do the prophylaxis or the prevention therapy, remember the regimen is not the same as when you are doing treatment. And therefore, it is very important to initially rule out the presence of an established case of TB. Because if there is an established case of TB and you still do the prophylactic therapy with those 2 drugs, you are likely going to create resistance. It's just like when somebody comes with an exposure of HIV and you want to do the prophylaxis, you have to establish whether the person is having the condition already or not before you initiate the prophylactic therapy. Here is the same. And nowadays, you do it whenever there is HIV diagnosis. But the best thing is to establish whether the person is already having the clinical case of TB or not. If you do it and the person is having a clinical case of TB, then of course, you don't need to do the prophylaxis. You do proper TB management. If the person is 0 when it comes to TB, then the individual qualifies to be given the TB prophylactic or preventive therapy. Drugs that are recommended include isoniazid. That was those days. Nowadays, we are using combination therapy. So even in pediatrics, now we are using isoniazid, rifampicin. So 3 months daily therapy. And in adults, the recommended combination is rifampicin and isoniazid, taken weekly for 3 months. For obvious reasons, pyridoxine is added because of the possible peripheral neuropathy that may be induced by the use of isoniazid. So this is the regimen, a combination of weekly rifampicin and isoniazid, and those days, isoniazid alone therapy for 6 months. Now, a brief look at leprosy.
So
Another condition.
Hello, sir.
Yeah, hello.
So are you saying
Hello.
that the monotherapy is not used at all? It's just the combination drug?
Not that, but for efficacy nowadays is combination. If it happens that maybe due to 1 or 2 reasons, the combination therapy cannot be done. Let's say the person can't take rifampicin, and of course you'll be restricted to the isoniazid alone. But all things being equal, now it is recommended that you do the combination therapy. All things being equal in pediatrics, you are doing these 2. So in case maybe you have any issues with rifampicin, contraindications or whatever, then of course you may have to do the monotherapy. But if there are no such issues, then it is better you do the combination therapy. For adults, it is always combination therapy, rifampicin and isoniazid. Are you okay?
So is the pyridoxine given in children as well, or just for adults?
Of course, once you are going to use isoniazid for this period and you suspect something like this, you have to give. The neuropathy doesn't affect adults. Once you are having a drug that decreases pyridoxine concentrations, then it becomes a threat. It doesn't matter your age, you are still exposed to the risk and you may have it. Going to develop neuropathies. That will not be nice. Please, are you okay?
Thank you.
All right. So briefly, let's look at leprosy. So leprosy is caused by another mycobacterium species. That one is called Mycobacterium lepra. The mode of infection is almost the same as that of TB. But this time, even skin contact or when you inhale droplet nuclei, you may get the infection. This infection will initially or normally affect the skin. So you may have skin lesions, but later on, it may deal with your peripheral neurons. It may cause distraction to the neurons. So it affects your skin. So you have the so-called skin lesions. And eventually you get distractions to the peripheral neurons. This makes the condition therefore present clinically with signs or symptoms like skin patches, that's the lesions. These are normally not painful. So they have what we call paresthesia, painless skin lesions, because you are having peripheral neurons distraction. You are not going to feel the pain. Eventually, if you are not lucky, you are going to get drop-off of digates, either your feet or your fingers may get drop out. Normally, we have two main forms, but some literature classify and add some intermediate. But WHO guidelines, for example, mainly classify this condition into two: the paucibacillary type and the multibacillary type. The paucibacillary type is also known as the tuberculoid type of leprosy. In this case, there are few lesions. Hardly will it go above 5 skin lesions. Few skin lesions are there. And normally, if you are to analyze samples for the presence of the Mycobacterium lepra, it may be negative. Few lesions. The paucibacillary type, also known as the tuberculoid type. Few lesions, hardly will it go more than 5 skin lesions. And then to assess and detect the presence of the TB may even be negative because you have few of them. For the multibacillary one, you have more lesions, more than 5, so 6 and above. And you are going to find the presence of the bacterium when you are to assess for possible detection. Obviously, the damage in the multibacillary one is extensive. Multiple lesions, you have drop-off of fingers, digates, what have you. While the paucibacillary one may only be the patchy stuff with some few loss of pain sensation here and there. And because of this, when it comes to the paucibacillary one, it is less extensive, and therefore you may use 2 drugs. But when it comes to the multibacillary one, there is no room for 2 drugs. You have to use 3 drug combinations. Previously, monotherapy was the recommended therapy. And because of resistance, nowadays, it is not advisable to use monotherapies. 3 main drugs are used in the management of this condition. These include dapsone, clofazimine, and rifampicin. Rifampicin is everywhere in TB, and here too we are seeing rifampicin. How does dapsone work? It also contains the sulfonamide moiety, and therefore it works almost like them. It inhibits folic acid synthesis in the Mycobacterium leprae, and therefore you need folic acid in this type of prokaryotes because they cannot utilize external folic acid. It is only the folic acid that they have prepared. That is what they can utilize. And of course, you need folic acid for protein synthesis. Any drug that inhibits folic acid metabolism will cause harm to numerous prokaryotes, numerous microbes, and therefore dapsone is a very strong agent. It is orally active and well absorbed within the GIT. One problem is its enterohepatic circulation. We discussed this. The drug moves out from the biliary system into the GIT, but since it is still fatty, it is reabsorbed, gets back into the systemic circulation in high concentration, possibly even still have activity. It is metabolized via acetylation, and therefore you could have slow acetylators. In these individuals, the drugs may accumulate, especially when you take other medicines or food substances that can even worsen the acetylation process. Adverse effects possibly includes hemolytic anemia. Remember, it's a sulfonamide. And of course, it can trigger hemolytic anemia. It can also cause peripheral neuropathy. If it is used alone, you may create resistance. So don't use it alone. The other one is clofazimine. This drug is also part of the second-line agent in TB management. It's a phenazine. It binds to DNA and inhibits its function, and therefore it kills the organism. It mainly acts by generating oxygen radicals. So the radicals will inactivate the DNA. It's also well absorbed orally, accumulates well in tissues, including even macrophages, but it doesn't get to the CNS, probably because of poor BBB penetration. It takes time for its effects to occur, and therefore you don't need to rush too much and say that you've initiated this drug and by 1 week, 2 weeks, you are not seeing any benefits. Some drugs do have longer half-lives. And remember, it takes about 4 to 5 half-lives to achieve steady state. Any drug that has longer half-life needs time because it means it will take longer time for the drug to reach steady state. For example, who knows the half-life of amlodipine? Amlodipine, class captain. Hello? Hello? Please, can you hear me? Hello?
Hi.
Yes, please. We can hear you.
Yeah. I'm asking if somebody knows the half-life of amlodipine. To cite it as an example, the need for us to have patience and advise the clinical team because they are expecting the effects to occur quickly. Amlodipine has a half-life approximately 48 hours. So for example, if a patient comes for admission, and then you put the patient on amlodipine on the ward, a day or 2 or to 3 days, you still realize that the BP is high. Amlodipine with its 48 hours half-life. How long does it take, or how many half-life does it take to reach steady state? Because the drug's effects are seen perfectly when they hit steady state, so that they could have a sustained control. In terms of BP, for example, you need adequate and consistent plasma concentrations before the effect becomes perfect, and that is achievable only at steady state. So roughly 5 times 48, then you are getting around, let's say, 10 days. So it may take approximately around 10 days before amlodipine gives you or reaches steady state and have total control. And therefore, if you initiate a drug like amlodipine, you don't expect the drug immediately to have total control of the BP. And with this knowledge, if, say, the clinical team are trying to rubbish the drug that is not working, with your pharmacokinetics and your knowledge in steady state and half-life of medicines, it's on you to advise the team, the patient, to have patience, because the drug takes that period to hit the concentration that can have total control. So this is an example. It's not only this, when you are managing several other conditions, some of the drugs may even take as long as 3 months before the effect is seen. If you are managing rheumatoid arthritis, for example, the DMARDs may take 3 months, 6 months, some of them even 10 months before the effect is seen. And it's all about hitting steady state. And obviously, drugs with longer half-life, you need to give them time to hit steady state before they work. So when you initiate clofazimine and you are not seeing any effect, please take your time, because it has a longer life and you are going to experience its benefits roughly around 6 to 7 weeks, if not longer. So it is better you assess it and advise the team as the person who is a custodian of medicines. Adverse drug issues include reddish, GI disturbances, vomiting, diarrhea, and what have you. You know, if you are managing the positive type, that is the tuberculosis, has no role anymore, because we don't want to create resistance. So, for example, you can combine dapsone and rifampicin for a 6-month duration. But if you are dealing with the multi-one, that is the lepromatous leprosy, that is more dangerous, that is more extensive, and you are supposed to combine all the 3 for up to 2 good years. 2 good years. Any questions? Any questions? Class captain, any questions? If not, then we will close for today. Next week, we will come and possibly start the musculoskeletal topics. Okay. Hello?
Hello. Please, can you hear me?
Yes, please.
With regards to the half-lives of drugs in achieving steady states, please, I don't really get a correlation between a drug having a long half-life taking longer for a steady state to be achieved, because I thought, as in example, amlodipine, if it takes 48 hours And if its half-life is 48 hours, I mean, during that entire 48 hours, is it not supposed to be working to give us results? So how then is it that
Okay.
it will
So what as in do you know about when to achieve steady state? What were you taught? Time to achieve steady state with reference to half-lives. What is the normal as in half-life? Is it just a single half-life or one half-life, 2, 3? It's 5 half-lives or 4 to 5
Hello,
half-lives.
Sir, please, can you hear me?
Yes, I can hear you. I'm saying that to achieve steady state of drugs, you need 4 to 5 half-lives. Most drugs to take 5 half-lives. So that's one time tablet that you have taken, and you are saying the half-life is 48 hours. You see, the drug need to load increase from 0. The first dose that you have taken, just before it, you had 0 concentration in your plasma. And therefore, it takes at least 5 different half-lives, let's say 5 doses, if you have to relate it to doses, before the concentration can build up and be maintained at a constant plasma concentration as you keep on taking the drug. And therefore, until you hit that steady state, stable plasma concentration, most drugs will not be able to have perfect control of the condition. But at that point, you don't have enough load within the plasma to be able to do the job for you. So just taking one drug, and the drug's half-life is 48 hours, obviously will not be enough because you have not hit that constant or steady state concentration. You've not hit that. And therefore, the plasma concentration at that time is not stable. It keeps on increasing and dropping, increasing and dropping. So the moment you take it, you have a load. In no time, it will drop to below the therapeutic window, and the drug effect will go shortly. But by the time you hit steady state, then what you are saying is that the plasma concentration becomes stable based on the amount that you take and the amount that will be excreted. By 5 half-lives of any drug, depending on the amount you are taking and the amount that is excreted, you have almost a near perfect concentration. That concentration, if taken well and the drug is excreted well, will be in the therapeutic window. It's not likely to be in the toxic window or sub-therapeutic window. And that is when the drug will have better control, especially in chronic conditions like hypertension, diabetes. And therefore, just one dose of the drug will not hit steady concentration and will not be able to have total control. It may drop around when you have maximum absorption, but it will quickly, its effect will wear off because it will drop again below the therapeutic window. Until you hit steady state, you always have peak and troughs. Peak and troughs. At peak, you may even have toxicity. If you are lucky, it will be within the window. That is when initially, at times in hypertension management, you have what we call labor hypertension. The moment you give the drug, it controls the BP. In no time, initial stages, you see that the BP is increasing again because the drug hasn't hit steady state concentration. So by 5 half-lives of the drug that you are using, you are always going to have a perfect steady state. And it is at that time that the drug can have constant control and to prevent issues like in hypertension, fluctuations. It drops when you take the drug. In no time, you go back and check, then the drug, the BP increases again because you've not hit steady state yet. For amlodipine that I use as the example, it has 48 hours half-life, approximately, and therefore you will need 5 half-lives. 5 half-lives, since you are taking it once a day, it may take approximately 2 times 5 times the 2 days, which is approximately 10 days. So when you initiate your patient on such a drug, you need time for the drug to hit steady state before you can have perfect control. As I said, other drugs like the DMARS, methotrexate, leflunomide, and those drugs may even take 3 months. Methotrexate is normally 6 weeks. The others, oral good, injectable good, leflunomide, and those, they may take even about 3 months or 6 months before they attain steady state and have proper control of issues like rheumatoid arthritis. Are you okay? So the initial dose may just go there and have increased plasma concentration. The BP will drop, but you realize that in no time it will go up again because you've not hit steady state. So if you are experiencing any of such things, once daily dose amlodipine, it will happen in the initial stages. If the team are expecting to have better control all through, you need to put in this your pharmacokinetic ideas that yes, the drug will work, but it will take time because its half-life is 48 hours. It will take approximately 5 times the half-life. So 48 times 5 is approximately 10 days. And therefore, they shouldn't rush. They should take their time. Once the drug hits steady state, it will be able to control. Are you okay? Hello?
Yes, thank you.
Yeah, so that the team will not go ahead and be adding additional drugs, thinking that the amlodipine alone is unable to control the BP. So they are introducing other antihypertensives. Meanwhile, if they take time and the drug hits steady state, that monotherapy alone may be able to control the BP. All right. So any other question? Have you started gout? Class captain.
Yes, please, sir.
You started gout.
Yes, please.
Okay, so then next week, I'll also start the other musculoskeletal conditions. Osteoarthritis, rheumatoid arthritis, and one endocrine but bone-related condition, osteoporosis. So we also start so that it's like we are all moving in the same direction. If you don't have any other question, it's raining. I saw your text that you wanted the class to cancel, but I wanted to come and then clear this short episode. So enjoy your weekend, unless maybe class captain, you have any announcement. Hello? Hello? Class captain. Hello? Hello?
So I think her network is not good.
Yeah, I'm asking if you don't have any question or any announcement from class captain, then we can close for today. We come back next week and then we continue with the musculoskeletal topics. So class captain, is there any announcement?
I don't think she's in the meeting. I think her network is
Okay.
not.
All right. So catch you next week same time. Enjoy your weekend.